One. Okay, hello everyone. Good evening. Thank you for giving us your time. Hopefully today will be an interesting session. I mean, we are all very familiar with antibiotics, and in Bangladesh, it's a crisis because antibiotic resistance is a growing concern, and we are also learning about antimicrobial resistant patterns. We are also aware about stewardship, but we tonight, have a very important guest. Dr. Sangeeta Sharma is one of the leading AMR dialogue personnel in the world. She is working as a professor in the Department of Neuropsychopharmacology in the Institute of Human Behavior and Allied Sciences of Delhi, India. She is a certified and trained MD in pharmacology, and she had her education from Harvard Medical School of Quality Leadership Program, Baldrige Excellence Framework for Healthcare Award, and she was also certified as an external assessor for NQAS. So we are very proud of her and confident in her credentials. Without wasting any more time, I would like to request Dr. Sharma to take over the stage and please give us some insights. Thank you.
Thank you, Dr. Abu Said and Hishik, for your kind introduction. I'm very happy to be here on this forum, talking to my Bangladesh colleagues. And I hope my session will be useful. I'll try to tailor it to a wider audience because this is something that which affects everyone, and all of us are using antibiotics and have different roles here. So let's see. I'll try to. You have to give me sharing. Make me a host.
Dr. Sharma, I think you can share now.
Okay, good. Yes, I can share now. Yes, you can see my screen.
No, now.
We can see it now.
Yes. Yeah, okay. There is usually some delay, lag period is there. Anyway, today I will be talking about what do you mean by rational use of drugs, how these irrationalities creep in our clinical practice, and how can we fix up? Because my job would be incomplete if I tell you only the problems. I need to tell you the solutions as well. How can we take care of this? Before that, I start with this. We must understand what is the role of antibiotics in today's modern medicine. The foundation of the modern medicine was laid down by discovery of penicillin in 1940. And this was one of the most important discovery of the century, which has helped us save many lives, treat serious infectious diseases. And today, if you look at the achievements of the modern medicine, they are all because of the antibiotics. If you look at the transplant, we are able to do the transplants because we have antibiotics. We are able to treat cancer patients because we are having antibiotics. We are able to do the surgeries because of the antibiotics. Now, what has happened over the years is, ever since after the discovery of penicillin, number of new subsequent antimicrobial discoveries followed, and we had a golden era of antibiotics. I call this as a golden era because one after the other we had a new class of antibiotics, and we thought that this problem of infectious is being taken care of now. But what has unfortunately has happened over the years is definitely with the advent of these antibiotics. If you look at this graph, this blue line, the number of deaths declined. It saved a lot of it. Again, even today they are saving a lot of lives. But look at this orange line. This is to do with the number of new discoveries, antibiotics that we did. Initially it matched, but now we see that no new antibiotics are coming in. You will say, how come it is right? We keep having new antibiotics coming, but remember, they are no new class of antibiotics. They are just the generations of antibiotics. We have cephalosporin group. You have first generation, second, third, fourth, fifth generation. Like we have fluoroquinolones, we have first generation fluoroquinolone, two, second, third, fourth, like that. So we have generations, but no new class is there. And now you will say, why do we need a new class? Now, why this number of deaths, which had declined earlier, is rising again, is because of the rise of this resistant bacteria. Now, this is what is this? Is this a new phenomena? You can write in the chat box. Is this a new phenomena which was not seen or anticipated earlier? I can see the chat also. You are not sure. Okay. This is not a new phenomena. This is, defense mechanism adopted by the germs and bacteria. This is, they are actually have been there in the universe even before we came in. And our whole body is occupied by these germs, and most of them, 90% of them, are good bacteria which we need for digestion, for manufacturing vitamins in our body. So they are protecting our skin. They function as a barrier. Nasal mucosa prevents infections. Oral mucosa also, like that. They have a very important role in our body. But what has happened over the ever, as we discovered more and more antibiotics, these resistant bacteria started appearing. So since this is a natural mechanism, biological mechanism, it was expected to happen. And Alexander Fleming, in his Nobel Prize speech, also mentioned about this, because he had observed this phenomena right at that time. And he anticipated at that time that there would be a day when these antibiotics would be misused, overused, wrongly used, and this a problem of resistance will grow. So, and that is what has happened. So this is because of the rise of resistant bacteria that we are now worried, and there are no new antibiotics that are coming in. For last 20-30 years, we haven't had a new class of antibiotic. And you being the pharmacy students and clinician, you know how difficult it is to develop a new drug, bring it to. And with the antibiotics, it has been observed that the moment a new drug is brought into the market, because of the overuse, misuse of these drugs, resistance develops. So within 6 months to 1 year time, 2 year time, you will find most of the patients stop responding. Now this happens because of the ability of the microorganisms to stop responding to an antimicrobial agent. You have an antimicrobial agent, but they are not responding to it. So this has become because of the ineffective treatment, when we haven't followed the standard treatments. And this resistant bacteria, there is a risk that now we are spreading these resistant infections to others. Earlier, I think Bangladesh is quite similar as far as it is related to TB. Tuberculosis earlier was sensitive TB. It was responding to first-line anti-tubercular drugs, but because it was a long-term treatment, patients did not complete the entire regimen. They left in between, or not adequate cover was given. Many patients these developed multi-drug resistant tuberculosis. Now today you find that the MDR it has increased so much, because now it is the MDR TB which is being spread in the community. Now, because of this problem, because these antibiotics are used, and the two most affected regions in the world are South Asian region and the African region. And poor are hit the hardest. So low middle income countries are hit the hardest. I mean that they don't respond. They have twin problem. That one, they have a lot of infectious diseases. Second is that they because access to antibiotics is also problem. That they don't respond to, because they don't have access, so they remain infectious for a longer time. Third is that, because they are infectious for a longer time, they spread these infections to larger number of people, and then there are more chances of rising antimicrobial resistance because of the natural mutation process, and misuse and overuse of these antibiotics, just in case that the patient may be having some bacterial infection, accelerates this process of antimicrobial resistance. And as I said, our problem has worsened because these antibiotics are used in human sector for human health, in animal sector for in animal husbandries, food production, and then because they are used in human, non-human, they are excreted and they find a way into the environment. Now, a word about the non-human use of antimicrobial. It is really worrisome because animals, like human beings, animals also fall sick. So when they fall sick, they need antibiotic like we need as human beings. That is all right. Therapeutic use of antibiotic is not a problem. Problem comes when we use this antibiotics for growth promotion of animals. If you look at this forced growth, normally a chick develops to the size of 1 kg in about 90 days time. So, but when you feed small, subtherapeutic doses of antibiotics to these animals, birds, they grow faster. So they reach this size in about 801 kg size in 30 days time. So this is what is worrisome, because then these antibiotics residues are there in the meat of these birds. So, and that's how, and when we eat them, these antibiotics get into our problem, and since we are exposed to antibiotics, resistance develops. So this forced growth is a real troublesome, and this happens because of the intensive farming, because these chicks are grown just for meat purpose only. They are not grown for any other purpose, and the infection, the sanitation and hygiene, these are overcrowded places, hygiene is very low, infections are very high in these farms, and when you add this to their feed, this forced growth becomes a problem. So everywhere you find now, in milk, in chicken, these antibiotics are sprayed over the crops. So everywhere, that's how they have got into our environment. And these, like we travel, because of the global travel ease, these bacteria also now travel. And same is true for the resistant bacteria also. They also travel with us. You all have witnessed this COVID pandemic, and you know how quickly it spread to the entire world. So I think it is not very difficult to imagine how these resistant bacteria are traveling and affecting everyone globally. Now, what are the factors? As I said, the development and spread of antimicrobial resistance is because of the use of antibiotics. If you use it, this AMR is bound to happen, because this is a biological, natural phenomena. Now, but what happens is, then you say, okay, should we stop using antibiotic? No, I'm not saying that at all. But when more we use, more we develop this AMR. So use is the key driver. If you even, because many times we have seen, even when you use for a right indication for the right patient, it has the potential to develop AMR. But when you use it, overuse it, so this whole process is accelerated. And this is happening because we as a doctor, we as a pharmacist, we as a patient are overusing misusing these antibiotics. Patients are not complying with therapy. They are taking 1 or 2 days treatment, then stopping once they feel better, or self-medication. They don't go to a doctor. They just take either the leftover medicines from the previous episode, or they share with their family, friend. So thinking that the this time also we have the similar symptoms, same symptoms, perhaps we need this. Last time my doctor, when I went to the doctor, he gave me this medicine, so last time, so maybe this will work this time as well. And as I told you, the use in animal husbandry, aquaculture, fishing, agriculture, so all these are responsible for these spread of AMR. Non-availability of or misuse of diagnostic support are also equally responsible, because many times when we speak to the clinician that why did you use antibiotics for viral infection, they say, okay, I wasn't sure whether it was a viral infection or a bacterial infection, or you may not have a facility to diagnose, differentiate between viral and a bacterial illness. So perhaps this type of use, we call it as just in case the patient may be suffering from some infectious disease, so we use this antibiotics. And of course, poor infection control practices are the most important factor, because more you fall sick, more are the chances that you will mix up between viral and bacterial infections, and more are the chances that the patient will get these antimicrobials. Now, coming specifically to antibiotics, if you look at the inpatient use and in outpatient use, you will find, at least I know in India, that we in outpatient, almost 80 to 90% of the patient will get some antibiotic in outpatient department, and the modest estimates for inpatient are 50%, maybe more. So and now, why this and how does this happen? This is because we are using these antibiotics to treat viral infections which are self-limiting, like upper sore throat, like watery diarrhea. We all know that these are viral infections, and they are self-limiting illnesses. Even if you don't give antibiotic, they'll get all right. But just because there is a confusion, or it is a habit, it's a behavior that we use these. Another very example is post-viral cough. A person had a viral infection, and once the infection is over, usually they get bouts of cough because of reactive airway. Because of the reactive airway, there are bouts of cough. So many people think that they still have infections, so but they will not respond to antibiotic. They don't need actually antibiotic. All they need is that maybe some relaxant, some home remedy, or some relaxant bronchodilator that will help the this bout of cough. So we this is the misuse. This is, we will call this as a misuse. Then second is the broad spectrum. When we can work with a narrow spectrum antibiotic, but we choose broad spectrum. For example, if a patient can respond to amoxicillin, instead of amoxicillin, if we give them cefixime, a third generation, fourth generation cephalosporin, oral cephalosporin. So this will amount to a misuse of antibiotics, because the principle, the dictum here when we are choosing these antibiotics is it should be as narrow as possible. Spectrum should be as narrow as possible, because the broad spectrum will kill other types of germs also. And as I told you in the beginning, that there are good bacteria, there are bad bacteria. So we need to kill only the bad bacteria. But what happens is, if you use the broad spectrum, once we are killing the good bacteria also. So this is what is harming us more. And then sometimes we are not prescribing according to the guidelines. Guideline says one drug, but we are using two drugs, three drugs. Or guideline says you need only one dose, or 5 days treatment, we are using it for longer duration. So these are all the respect. If you look at this slide, here are the 9 common areas for improving antibiotic prescribing. So each one of the areas, you will see there is a scope for improvement. So now let's see, I already told you about over prescribing, wrong choice, overly broad spectrum, wrong dose, wrong duration, irrational combination. This is another area of concern. Many a times 2 3 antibiotics are put together in a fixed dose combination, and we don't need. First of all, you may not need all of them. Secondly, the choice of antibiotics in that fixed dose combination, they may not have, they may be antagonizing. That means they have opposite effects. So unless they have a synergistic effect, we should not be combining antibiotics. So, and also, these last two ones, omission or delayed doses, wrong dose interval with antibiotic, it is very important that these should be given. If you look at the regimen prescribed is 6 hourly, 8 hourly, 12 hourly, 24 hourly. Why? Because there is a logic behind it, rationale behind it. So but we very often mix it up with the TDS, BD once daily. Here we need to maintain the hourly dosages, because it is, with antibiotics, if you remember, you need minimum inhibitory concentration of these antibiotics in the blood to take care of the infection. So if you don't follow this interval, then the levels, minimum inhibitory concentration will go down, and the bacteria will not respond. So will not respond means that the patient will continue, the germs will continue to multiply, and and then they will not respond. So many times we come across that the patients come and demand for it. They may have some anxiety, high grade fever is there, or they may have some misconceptions. Many think that any fever uh, should be treated with antimicrobials, and economic concerns could be there. In days of corporate world, we don't want to take leave. We have to go back to work. So and for self-limiting illness, you may have to take a bed rest, stay at home. So but we don't have that kind of time. So many of times we because of these concerns, we take antibiotic. Kal bhi lena hai, so let me take now to get better. Similarly, if you talk to the physicians, I feel there is a lot of mix up happening between real or perceived pressure from the patient. Many a times, we presume that the patient is asking for it. Whereas if you talk to the patient, they'll say, we never asked for it. I just told my complaints to the doctor, and he had felt it okay, then only he has given me, so I'm taking it. So this is not a real pressure from the so don't assume that the patient is asking for this. And many times we also see that most of the doctors, they know that these antibiotics don't work on for as a antiviral agent. They don't work on viruses. The knowledge is there, but we are not applying. So there is a cognitive dissonance. The knowledge is there, but we are not acting on it. So this could be the and then there are regulatory issues which can also fuel or accelerate this AMR is because of the over-the-counter availability of these antimicrobials. Most of the patients, they go directly to the counter and ask for these antibiotics without prescription. So again, that viral, most of these patients are actually viral upper throat or diarrhea patient, but they then get these irrational fixed dose combination, wrong compounds, or pricing, the latest one, or the latest broad spectrum ones may be expensive, maybe more margin is there. So, and also at the same time, quality of these antimicrobials is important because there are a lot of substandard counterfeit drugs in the market. So if the potency of the antibiotic is not good, again it will accelerate AMR. So here it is very important that the quality of these antibiotics should be ensured. So and of course, as I said, these antibiotics, they give a false sense of security. We think that we've taken care of infections by just giving these antibiotics, but there are other things that you need to be looking at it. Antibiotics alone will not be able to help you much about it. Then consequences, as you know, are very, very serious. Simple infections like sore throat, ear infection, urinary infection, abscesses, TB, malaria, they are becoming difficult to treat. You need higher end antibiotics. You need second line antibiotics, which are more toxic, which are more expensive. So, and urinary infections, if you see, earlier they could be better with the oral medicine, but now generally if you look at the antimicrobial susceptibility test report, you'll find most of them are not responding to these oral antibiotics. So you need to give injectable antibiotics to this. And of course, I told you about TB. Now it is MDR TB or the XDR TB, which has become a major issue. And this results in treatment failures, death, longer treatment, hospitalization, prolongation, and uncontrollable epidemics. Ever since after this COVID, if you had observed, there are, every now and then we hear in the news that there is a Nipah virus outbreak, there is a Zika virus outbreak, there is this outbreak, that outbreak. So these are all because of this, because nature is always in control. If you overuse something, so nature will try to bring it under control. So and now at least I think we can imagine the horror and the consequence of importance of running out of good effective antibiotics. Now you can imagine, we are actually going back to the pre-antibiotic area where we did not have, we were losing our patients because there were no antibiotic. But now today we are losing out on patients even with the presence of these antibiotics, and we cannot afford to do this, lose these, because our pipeline is running dry. Pharmaceutical industry is not interested in discovery of new antibiotics. Besides the time, efforts, money required for development, major problem is that this AMR. Because the moment the drug is brought to the market, within 6 months to 1 year, the alarming resistant pattern develops, and you need another drug for that. So they don't get good return on investment, so they are not investing in antibiotics. They are more now interested in developing therapies for non-communicable diseases like diabetes, obesity. You can look at their, they get good return on these, but not on antibiotics. So that what the message I'm trying to give here is that there is a immediate dire need to protect the existing antibiotics, rescue the existing antibiotics. If you don't do that, we will be losing out and we will not be able to sustain this. So, and avoid this excess versus excess barriers, because both can lead to AMR. So then we need to balance out. Individual use may have been justified in certain situations, but you need, with antibiotic, you need to look into the societal impact of it. These are a group of a drug which does not alone have individual impact, but they impact on the societies, because once the resistance develops, that resistant infections spreads in the community. So you need to control that resistant pattern to protect the communities. Many hear many clinicians saying that it is my individual patient, I need to take care of it, they need to be getting better. Of course, you need to save your individual patients, but remember that it has a larger implication on the society. It is not like paracetamol. It is not like diabetes medicines which will impact the that individual. It is the society who pays the cost for it. And OTC sales is something with antibiotic. I'm not the whole regulatory structure has to be in place. Ideally, no drugs should be dispensed without prescription, but particularly with antibiotic, this should be avoided because uh, you know uh, as I said, these are different class of drugs which have a larger implication. So we need to be protecting against this. And one thing is very, very clear, that this AMR cannot be halted. You cannot stop it. You can only contain it. You can slow down the process, but you cannot stop the process. So main priority with us is to prevent infections, so that there are lesser chances of infectious episodes where you may be uh, prescribing these antibiotics. So containment, once first prevention, then containment is the next best option. And you need an integrated approach. You cannot just look at the antibiotic prescribing. You need to look at the infection prevention control, and you need to also look at the diagnostic stewardship, because more once you make a diagnosis, you are likely to choose a right treatment, and the success of treatment would be there. But if you don't make a diagnosis, you're just hitting it in the dark. Oh, let me try this, that, something may work out. That kind of approach will fuel this antimicrobial stewardship. So rational drug use of antibiotics require that we have stewardship program in place. This is nothing else but just the when we are combining these we are preventing the spread of infections and reducing the antibiotic use. You want to control the usage here, and it is just the coordinated set of actions. You are observing how much is being used, and then in which patient which antibiotic is being used. If you look at that and regulate that, optimize that, some of the problem of these AMR will be reduced. So basically, when I say antibiotic stewardship, the idea is to reduce the drug resistance. and ensure optimal use of antibiotics by all providers. This includes clinicians, pharmacists, patients, everyone. And this, is the pivot of this is that patient safety. This is a patient safety concern as well, that you start with the right drug, right dose, right duration, and de-escalate at right time. With antibiotics, we need to look at the de-escalation as well. Sometimes the patient is sick, you are not sure what the patient is suffering from. You may have to start these antibiotics, especially in emergency, when the patient comes with sepsis or urinary tract infection. So where you don't know what is the exact pathogen, you may have to start with broad spectrum antibiotic. But once the microbiological samples are taken, you identify the germs, you know the sensitivity pattern, you should reduce to narrow spectrum antibiotics. So I'll be talking about this antimicrobial stewardship. There are six components here. Each of this is very, very important. Leadership and commitment, of course, is required. Your hospital head, principal, director, whatever you may call, that commitment should be there. Then there are certain antimicrobial stewardship actions. I'll be talking about what is relevant to you, and then we need to educate and train people on monitor the use of antibiotics, development of this AMR in your local area, in your lab, report and give feedback to the clinician. This is the current status, so that they can modify their prescribing practices. And of course, each one of us is accountable and responsible. It is not like that, go and fix that person first and then come to me, or clinicians blaming the pharmacist, or the pharmacist blaming the clinicians. Each one of us, including the nurses, also have a important role here in antibiotic stewardship here. So some of the things that you can do in your hospital as a pharmacist, as a clinician, as a nurse, I'll be just quickly talking about this. There is one approach that is widely advocated, is formulary restrictions with pre-authorization. Here you restrict the formulary, that you say that certain antibiotics can be given only in ICU. Certain antibiotics can only be given in IPD patient. Only these are the antibiotics which will be given in the outdoor department. So that way you try to regulate the use of overly broad spectrum antibiotics, because if you develop resistance to these broad spectrum antibiotic like piperacillin, meropenem, imipenem, then you don't have any other drug with you for the treatment of the patient. So you may be losing these patients because they don't respond to. So formulary restriction help us to preserve the power of existing antibiotics. Then you can do the audit to look at
Sharma.
what method is working, what method is not working. And of course, this is a work of multidisciplinary teams. It is not only that the clinician will be able to fix it, or the pharmacist only, nurse only will be able to. All of us need to get together and see, because all of us have a role to play. And then, of course, adherence to the guidelines is very important. Then there are few strategies. I'll come back to this. You need, first of all, if possible, try to see that a stewardship team is in place. This is usually a multidisciplinary team where clinicians, pharmacists, nurses, quality control, administration, surgeons, pharmacists, everyone comes together and looks at this problem and see what can be done. Regarding guidelines, you can follow the existing guideline. I believe you also have a antibiotic policy or national action plan on AMR. If you have guidelines, your own, follow it, or you can adapt the guidelines developed by others. Like in India, ICMR and NCDC, they are developing these guidelines. We also have the standard treatment guidelines, which include the treatment of infectious diseases. We have been doing much before ICMR and NCDC. We had been doing this 2002. So now these days we have 7th edition. So you can refer to the existing one. You don't have to reinvent the wheel because people have already done that. So formulary restrictions with pre-authorization restrictions, I told you that you restrict the antibiotics according to the area of use. And then because this, for example, I give you an example. Cefixime, a fourth generation cephalosporin oral, we need to protect it. This is a very, very good cephalosporin that we have. But if we use it in outdoor department for trivial illnesses where it's not required, resistance will develop, so we will lose on it. So we will not put cefixime on the outdoor list. We will keep this only in the indoor list. So like piperacillin and all these, imipenem, these will not be used in IPD. Similarly, for example, I'll come back to this. For this, WHO has given aware categorization. Aware, A stands for excess, WA stands for watch, RE stands for reserve. So they have categorized all the antibiotics into these three categories. The main aim, as the name suggests, excess, is that here you want to improve the access to antibiotics. Those who do not have these antibiotics available, those rural population or far from people who are living far away, if they don't have access, here you want to improve the access to for treatment of some basic infections. Reserve, of course, as you say, these are the last resort antibiotics, should be reserved only for multi-drug resistant infections. In between are the watch category. These antibiotics have a high potential for AMR. So we need to watch the trends in use of these watch group of antibiotics. Now, what all is included in these category? In the excess group antibiotics, you see these amoxicillin, amoxicillin clavulanic acid, penicillins, cephalexin, first generation, second generation are here. You see doxycycline is also here, gentamicin and amikacin, because these are life-saving antibiotics in some septicemic infections, so that is why they are here. So sulfamethoxazole, these are here. So as per WHO's recommendation, most of the prescribing should be from this excess group of antibiotics because they have a low potential to develop AMR. Now let's see what are included in the watch group. The watch group has azithromycin, cefixime, third generation cephalosporin, third generation fluoroquinolones, minocycline. Even not all tetracyclines are included in the some doxycycline and tetracycline are in the excess group, but minocycline is in the watch group. Now, what is the implication in your practice for both clinicians, pharmacists, and nurses? Sometimes even if when you are not sure about what is it, viral or a bacterial infection, if you have to choose, if you have to give antibiotic, give only from the excess group. That you can prescribe doxycycline in adults, but not azithromycin, not cefixime. in COVID times, we saw overuse of azithromycin. This has a misuse potential because azithromycin is given as a single dose antibiotic. So people find it convenient. Adherence is better, and it is a 3 days course or 5 days course. So people taking a single dose is convenient. So that is why we prescribe. But this is a watch group of antibiotic. So we need to protect this because this azithromycin is very, very useful in other infections as well. So we need to so whenever you are in a situation, there is a demand or the patient needs it, you're not sure what the infection is, choose an excess group, doxycycline or a amoxicillin or sulfamethoxazole over others. Okay, so then of course, you know why you need to protect fluoroquinolones, because these fluoroquinolones are now part of the second line TB treatment. If you use these fluoroquinolones empirically without any diagnosis in a patient who could be tuberculosis, suffering from tuberculosis, the infection MDR may develop. So that is why do not use these fluoroquinolones in undiagnosed TB patients. So if you suspect that the patient could be tubercular, then don't use it. Then, of course, meropenem, imipenem, piperacillin, venco, tico, netilmycin, these are all high priority watch group of drugs that we need to monitor, because if resistance develops to these group of antibiotics, you will not have any other drug. At least we don't have access to the reserve group of, some of them are available, but most are not if resistance also develops to these, you can imagine what will happen. Linezolid is another misused drug. Drugs which are given orally from this reserve group are again misused, overused, so resistance can be a problem. One more thing that you can try is that you um, you know change these antibiotics over a period. For example, if you're working in a hospital, then you can keep the excess group, and maybe you change the group. It will reduce the pressure on these antibiotics. I'll give you an example. Chloramphenicol, you must have all read, was being used for typhoid. Then a time came when the resistance developed to chloramphenicol. Patients stopped responding, so people switched to the other antibiotics. Now the cephalosporins are used, azithromycin is used for typhoid treatment. So now if you need, if the patient is, now we have seen that resistance is developing to cephalosporins or azithromycin. So now if you need something, if you use this chloramphenicol, the patient is responding. So this has happened because when the use declined, the pressure on the germs for development of AMR also slowed down. So the bacteria came back to their normal. So that is why they became sensitive. So that is one way. Then another is that you can use computer assistance here, patient specific recommendation. Nowadays there are a lot of softwares available where antimicrobial stewardship principles are embedded in the software. So depending on the patient's age group, type of infection, diagnosis, the computer may suggest you a treatment, a most appropriate choice of antibiotic. So that's another very effective way of regulating the use of antibiotic. Then another very effective strategy for reducing the antibiotic uses, antibiotic timeouts. In emergency, for example, patient with septicemia, if they have come, you may have to use, because you don't know the bug, you don't know the source of infection, you don't know the sensitivity pattern. So you may start with the broad spectrum antibiotic, but within 48 hours, 72 hours, you start getting the reports, you identify the source of infection, you know the sensitivity pattern, so you can switch to the narrow ones. So, usually 48 to 72 hours, many hospitals, they have this policy. They will stop pharmacy will not supply these antibiotics for this patient unless the consultant reviews and then says, okay, continue or switch to a narrow spectrum antibiotic. So, or switch to an IV, from IV antibiotic to an oral antibiotic. So, this is a very good strategy being adopted by corporate hospital where this system works very well. So, patient does not get overly exposed to a broad spectrum antibiotic. Then comes with the antibiotic, well, there's one more thing. More than prescribing, it is the stop decision which is very important. Actually, this gets ignored. We do start with the antibiotics, but we don't think about the duration of therapy. We don't have any action plan. We don't write it in the patient's case sheet that we continue for 3 days, 5 days, 7 days, 10 days, depending on the type of infection and the site of infection. So sometimes what happens is the patient may receive these antibiotics for longer than they require. For example, many times you may have also come across the kind of situation. The nurses in the ward, they may remind you, oh, doctor, this patient is receiving antibiotics for last 14 days. Should I continue? And the doctor may astonish, when was this 14 days given? But then you realize, it was continue same treatment, continue same treatment when they write. So antibiotics were also continued. So it is very, very important that the stop decisions are also recorded in the patient case file, so that the nurses know that this antibiotic, a single dose is required, or 3 days or 5 days, 7 days, according to the doctor's plan. So this prescribing is very important. Here, when indication, what is the indication for prescribing? For this, you use the pharmacokinetic and pharmacodynamics of these antibiotics for choosing the right antibiotic. As you know, pharmacokinetic means how body treats the drug. That means how would be the absorption, metabolism, distribution, excretion of these drugs from the body. So that's true for all antibiotics. So that's the pharmacokinetics. But what is the pharmacodynamics in relation to antibiotic is, dynamics as such is what the drug does to the body. Now here, when we talk about antibiotic, here we mean what the drug does to the germ. Instead of a body, we are talking in terms of what the drug does to the germ here. So there are certain relationships, between drug concentration and effect and their toxicity. There are certain features of certain antibiotics. I think this will explain you better. For antibiotics to be effective, you need a dosage regimen. You need to achieve certain concentration in the blood, and then you also have to reach a certain concentration at the infectious site, and then to have this biological effect of curing this infection. So all this is determined by the minimum inhibitory concentration. So if you talk about these first three, this is pharmacokinetics. And if you talk about the biological effect, it is pharmacodynamics. So and then broad spectrum and narrow spectrum. Broad spectrum means they act on various gram negative, positive, anaerobe, aerobes, so they have a wider spectrum. That is why they are called broad spectrum. Narrow spectrum are they act on one particular single type of bacteria, either cocci or bacilli or gram negative or a gram positive, like that. So those are called the narrow spectrum ones. Then you know that certain bacteria, we use two terms, bacteriostatic and bactericidal. As the name is suggesting, bactericidal means they kill the bacteria. Okay, and the bacteristatic is which stops the multiplication of these bacteria. Now, what is the implication of this knowledge in clinical practice? Bactericidal, as the name suggests, they kill the bad bacteria, the pathogenic bacteria. Whereas bacteristatic, if you don't completely, stop the multiplication, they will come again. They will start multiplying again. So you have to think about the duration accordingly. So you should know, but this is not a very strong foundation, but still it can help you in understanding, in selecting the antibiotic. Some of the drugs at higher concentration, they become bactericidal. So these are the, you should remember this, what kind of effect they have on bacteria. So then, because the right exposure will decide the efficacy and the time to cure of infection, it will reduce toxicity, cost, reduce selection pressure on these bacteria. But of course, then if you are seeing patients in ICU, obese, or patients with renal impairment who are on dialysis, renal replacement therapy, pediatric patient, and in pregnancy patient, you need to alter the dose of these antibiotics to adjust those pharmacokinetic variability in these patients. I don't know, since you are majorly pharmacy group, but you remember the, for certain groups, certain antibiotic, we say that it should be given as a continuous infusion. Or for certain antibiotics, you give repeated injections. So extended duration, continuous or frequent infusions are given, because for them, this is time dependent. The more the time of exposure to the antibiotic, more killing will be there. Whereas for certain drugs like aminoglycoside, daptomycin, metronidazole, they are concentration dependent. Once you achieve that MIC, minimum inhibitory concentration in the blood, the killing will continue. So that is why they need only once daily injection. So you understand the rationale behind it. And for other drugs, you take both time and the exposure, for how long the MIC was there, and which can kill the bacteria. So vancomycin, fluoroquinolones, linezolid, they follow this exposure dependent. So that's the genesis why are certain. So for example, beta lactams, carbapenems, they need to be, given as a because they are time dependent, so they are given as extended. So sometimes you may need the loading dose as well. So first dose, as the drug is given, it achieves a peak level. Then the levels fall. Second dose, there is a levels will rise, will fall. With third dose, rise, fall. This is there. It takes 4 to 5 half lives for any drug to reach the steady state. Steady state means where all the peaks and the troughs are equal. So that means, it will not go beyond this. So this is the effective dose. But it takes 4 to 5 half-lives. So this depends. If the drug has a short half-life, you can achieve this steady state quickly. But if the drug is having a long half-life, it may take few days time. So sometimes when the patient is very sick, in septicemia like condition, you may have to give loading dose to overcome this 4 to 5 half-life lag period. So cholesterol, vancomycin, they are loading doses given. So if you in septicemia, when you want to give these drugs, and if you don't give loading dose, this will amount to irrational use of antibiotics. So you should know which drugs will require loading dose. And then I think patient factors are also important. Renal impairment, which antibiotics are cleared from the kidney, which are excreted from the liver. So depending on that, you will decide if the patient is having renal impairment. So you will not give drugs which are excreted from the kidney, because otherwise they will accumulate, because the kidney cannot excrete it, so they will accumulate in the body. So you may have toxicity because of these renal impairment. Or the other way may happen, liver, hepatically cleared drugs. If the liver is impaired, liver failure patients are there. So if you give these drugs, they will accumulate. So obesity, pediatrics, very small child, does not have mature organ systems to handle that pharmacokinetic part. So again, these children may get overdosed very quickly. So you have to be prescribed
Sharmila.
milligram per kg. So like that, depending on the pharmacokinetic, principles of the drug, you choose these antibiotics. For example, aminoglycosides are good in sepsis, but they don't penetrate soft tissue, bone joints, lungs, and CSF. So don't give aminoglycosides for these. Beta lactams are, on the other way, have a good penetration in soft tissue, bone joints, lung. So, but they do not penetrate abscesses. This is very important. Many times we try to treat the abscesses with antibiotics. Actually speaking, because none of these antibiotics penetrate into the pus, so you have to do the incision and drainage. If there is a wound, there is a pus. If you don't drain that, if you don't debride that, the drug antibiotic will not reach the site of infection. So no matter what dose you give, it will not be effective. So source control, incision, is very, very important. So must look into that also when you are doing this. So then there are certain which can penetrate into the tissue. Like that, I think I can stop here. One more thing that I would like to see, which are the hospital areas where most, one is in outdoor department for this sore throat, watery diarrhea. Most antibiotics are misused. Second misuse happens inside the hospital in surgical patients. The guideline says that before incision to the patient, you need only one single dose of antibiotic. You need just one single dose of antibiotic, and that too 60 to 120 minutes before the incision is given. Just that. You don't need post-operative antibiotic. But on contrary to this, we find that the most patients, surgical patients, they keep receiving these antibiotics for 10 days, 15 days. Many places I've seen that they are receiving 2 or 3 antibiotics. You just need to look into the skin preparation, glycemic control. Sugar patient, diabetic patients, they are more prone to infections. So they are having infections because of the high blood sugar, not that because the antibiotic was given. So these antibiotics are again here used as a shortcut for skin preparation, shortcut for proper wound handling, shortcut for normothermia should be maintained. These patients, the body temperature falls, then they become more susceptible to this. So all these, many times the patient is some tube is inserted. So people continue to give antibiotics for as long as the tube is in place. Again, one single dose is required. You don't need the lastly that I was about to say was de-escalation is very important. You need to de-escalate from broad spectrum to narrow spectrum, From IV to oral antibiotics, this will reduce the pressure. From high dose to lower dose of antibiotic, from combination of antibiotics to single drug. So any of these can, and I think the most easiest is to, switch from IV to oral. The more the patient is on IV, more are the chances that they will get more infections. Then duration is very important. Don't give prolonged durations of these antibiotics. Shorter is often enough. Now, pneumonia, for example, these days, they just say 5 days of antibiotic is enough. 5 days. Earlier, we were giving it for 10, 14 days, then it was reduced to 7. Now, the evidence is there, you just need to give it for 5 days. Similarly, for this cellulitis, 5 to 7 days. Urinary tract infections, 3 days treatment is enough. So don't expose these patients for long and for surgical patient, one single dose is enough. I think today I don't have, it's already 8 o'clock. I can, IV to oral switch is done once the patient is stable. IV drugs are given only because they have some problem in eating, either they are vomiting, they are not retaining. So IV route is given. But once they are stable, this vomiting stops, you can switch to the oral drugs. Oral options are there. All you need to look at is the criteria. When can you switch to IV to oral? I think antibiotics are, before you prescribe or dispense or administer, um, think about it, stop, think, and for just ask one question: are antibiotics really necessary? Can I manage my patients with a supportive treatment? For example, pharmacist, when the patient comes and requests for over the counter antibiotics, you can always counsel them that for fever they can take paracetamol. If there is a lot of rhinorrhea or other, cetirizine can help, or some home remedies can help. Antibiotics are not needed. They will get better 3 4 days time, fever will get down. So watery diarrhea, focus should be more on the rehydration with ORS rather than antibiotic. You find standard ciprofloxacin, tinidazole, or secnidazole or nidazole, whatever is available is given. They are not needed. 90% is viral, and mixed infections are very, very rare. Bacterial gastritis, enteritis will be there. The patient will have blood in the stool, and nobody will miss that. So if it is watery diarrhea, it is the viral infection. ORS rehydration will help. It is the dehydration which kills the patient, and antibiotics don't save these patients. Even if you give this antibiotic to this patient who is dehydrating, you will not be able to save. So you have to correct the correct cause, then only you will be able to. So as a pharmacist, you need to counsel these patients, explain to them why antibiotics are different, why they should not be sharing. As a hospital pharmacy, your role is that you make the antibiotics, proper antibiotics, available at the right place. Because if sometimes you may be using higher end antibiotic because the simple one is not available. I have seen amoxicillin was not available in the hospital, so they were using cefixime. So here comes the role of pharmacist, that you ensure that there is an uninterrupted supply of these antibiotics, so that you don't make irrational choices here. So and then explain to the patient, because you are the last link with the patient. and they feel more comfortable asking you about the questions. So this is the opportunity with you, that you can prepare your patient. Those of you who are doing clinical pharmacy, they can join on the rounds. They can watch this, do the surveillance, how much antibiotic, which antibiotic, where it is being used, and then can guide the clinicians accordingly. So ultimately, if we don't talk about this, we will enter into the post antibiotic era. In fact, I say we have already entered, and AMR is a silent pandemic. We are not realizing the number of deaths with AMR are much, much more than the COVID deaths that we had during COVID pandemic. But if we don't take care of it, you can imagine, you can see patients dying even in the presence of these antibiotics. I think I'll stop here. If you have any questions, you can ask me.
Thank you, Dr. Sharma. I'll be requesting the participants, if you have any questions, please ask her and we can move forward from there.
I hope I try to tailor it to various diverse or audience. But we should know, even if you are not directly prescribing, but you should know the principles behind it. Then only you will be able to participate in the team meetings.
Professor Sangeeta, also some medical doctors have joined, though the most of the participants from the pharmacy background, but medical doctors have also joined.
I believe Dr. Huda has a question, please.
Yes, thank you. Hello, ma'am. How are you?
Yes.
Okay, I'm Dr. Sharmila Huda, working as Associate Professor in the Department of Pharmacology in Bangladesh Medical College.
Okay.
So
Okay.
I have a question that you have mentioned rightly regarding the antibiotic de-escalation or the restricting the use of reserve group of drugs like linezolid, or reducing the duration of the antibiotic, like for urinary tract infection for 3 days or for 5 days, not more than that. But in spite of these things, in standard treatment guideline, the clinicians somehow they do not follow these things, and I don't know where the problem lies. It is not that they are not good in heart. It is not that they do not know the process, but it is still, it is most commonly seen in the outdoor emergency that linezolid is most commonly used in any infection, though it should be kept in reserve group. So my question is the scenario same in India? If
Yes,
this is,
people are the same, behavior are also the same. It is only maybe the matter of degrees, somewhere it may be more or less. But somehow, that's what I said, cognitive dissonance. They know that this is wrong, but still they are doing it. It is the fear. Most of the antibiotic prescribing I find is fear driven rather than the evidence driven. So here comes the role of pharmacologist, also, being the part of the team, that you tell them, perhaps they don't know what is the impact of this kind of a behavior, that we are losing out, how many deaths are happening. Sometimes they say, "Abhi ek hi patient mein to diya tha." I hope you understand Hindi. This was the only patient where I used this. But when you go back to them, do this prescription audit, tell them, oh, you have been using this for 9 out of 10 patients, then they may be thinking, for example, you can, pharmacologists, you can help them in auditing what is the average duration of treatment that they are giving. What is the, DGD is the methodology to measure the extent of antibiotic use. So if you go back to them, show them this is what is the data saying, then perhaps they will listen. This is what we do. we go back to them with the data. Otherwise, they'll say, "Oh, I am not doing it. So and so is doing it. My practice is very rational. I don't use this." But when you go back to them with data, you don't have to name anyone. Actually, I want to caution you: no, don't name anyone. Don't blame or shame anyone. It is, you just collect data, anonymize it, and say, in your facility or in my hospital or in this department, this is what is happening. So perhaps they will listen to you.
Okay, thank you.
Dr. Sharma, if no one else has a question, I'd like to close with a question from myself. So, a lot of the
Yeah.
pharmacy personnel that joined today's call also closely work with oncology, which I do as well. So we have a common question of oncologists prescribing antibiotics because a lot of patients do suffer from severe infection. There are suppression issues and all of that. But from your perspective, could you give us a little short note on the awareness and the need of awareness of oncologists and the oncology professionals in case of AMR?
I, I I think this is one area where it is needed the most, because cancer patients are immunosuppressed patients and they are at risk of developing more infections. So, and if we don't use proper antibiotics, we see patients, they survive cancers, but they succumb to these infections.
Yes.
We've seen patients surviving of the cancer, but they're dying of the infection in the ICU. So, of course, there is, I think there is no other specialty where, it is so stark, so grave. So, need is there. Again, antibiotics, because these are immunocompromised, they may have other renal problem, they may have other organ system failure. So, you need diagnostics, identification of the germ is very important here, because then only you can target your therapy. So, many a times, we find this correct sample is not collected, or no sample is collected for microbiological testing. And this has to be done before starting antibiotic. Even a single dose of antibiotic can render your culture sterile. You'll find that there is no growth. So the samples have to be drawn before first dose of antibiotic is given to identify the germs. Then secondly, how do you handle your sample? Sometimes storage is not proper, transport is not proper. So that is why all these things, as I said, you need an integrated approach. So oncology is a setting where you need more than anyone else that this integrated. So priority here in oncology should be prevention. So that hygiene, PPE, how do you prepare your antibiotic vials? Nurses, I talk about how do you prepare? Usually these are in powder form. How do you reconstitute? Some of them can be shaken, some cannot be shaken, some have to be, left for 20 minutes, half an hour before you can infuse. So for some loading doses to be given, for some continuous is. So all these, everyone in the team, the clinician, nurse, the pharmacist, everyone needs to be on board here. Then only you will succeed treatment in oncology patients.
Thank you so much, Dr. Sharma. That was valuable insight. Uh, I would like to ask Dr. Musaddiq if you'd like to give a few brief sentences before we start closing up.
Thanks, Professor Sangeeta. It was actually very informative presentations. Actually, we are arranging the four webinar. This is the second webinar. In 28th November, Professor Sangeeta will deliver the second speech on management of the common mental disorder. Before that, on 18th November, same time, Dr. Rashiduzzaman Johnny from the South Korea will deliver. It was the third. It will be the third webinar. Introduction to the PBPK modeling. So thanks everybody. Thanks, Professor Sangeeta, for your valuable time to join. Hopefully, another session is going to another session. There is another speech in tomorrow. So far, I know. I have shared among the different groups of the doctors. Hopefully, more doctors from the Bangladesh and more pharmacy students and the faculty from the Bangladesh sites will join, and they will get the valuable information from your speech tomorrow. Thanks, everybody. Please, Rishik, please wrap up the session.
Okay, so thank you again. I know it's late, but thank you for your participation. I'm pretty sure we learned something, and I'm pretty sure we're gonna learn even newer things on the upcoming 2 webinars. I'm very excited about the management of common mental health disorder because I feel like these are problems that are very South Asia specific, and we are not exactly aware of it. All right, I'll be closing it. Thank you, Dr. Sharma. Thank you, everyone. Good night. See you
Okay,
next
my
time.
pleasure.
Okay.